Welcome to Chapter 29, Chest Injuries. Here's a slide you can read. The big issue is the items inside the chest cavity, or the thoracic cavity. Blunt trauma and penetrating trauma are both large issues for us to deal with and manage. Obviously, we immediately treat injuries that interfere with normal function of breathing. Internal bleeding could be a big issue for the heart cardiac tamponade, where the sac that the heart is in fills with blood. The heart then cannot properly pump. Air collecting in that chest cavity is also going to cause issues for the lungs. Air should be in the lungs, not outside and around them, right? So remember, words have meanings. Ventilation and oxygenation. We've discussed ventilation and respiration, right? Ventilation, the ability to get air in and out of the body. That's our breathing. Oxygenation is delivering the oxygen to the blood by diffusion from the alveoli, following inhalation into the lungs. So ultimately, oxygenation is getting the oxygen from the lungs into the blood, our gas exchange, and then respiration is that oxygen passing into the individual cells throughout the body. The thoracic cage is half of the trunk, right? From the neck down to the diaphragm. Everything below the diaphragm is the abdominal cavity. While the thoracic cavity is the cage that protects all of our vital organs, it's also the mechanism that helps us breathe. So our striated muscles are the muscles in and around the ribs that help expand and contract with our diaphragm to cause negative and positive pressure for breathing in and breathing out. So the neurovascular bundle lying closely along the lowest margin of each rib, not the biggest of our concerns. They can get damaged during chest trauma, and that is a small concern, but it's definitely not the biggest issue we're going to face in this topic. The pleura, which covers each lung, and the thoracic cavity, there's different pleuras, of course. The visceral pleura lining the lungs, with the parietal pleura. So the parietal pleura is on the outside. There's a thin layer of fluid, and then the visceral pleura. Remember, we discussed something called pleurisy, which is a viral infection of the fluid in the pleural space. This fluid is necessary to keep the lungs themselves from rubbing on, the rib cage, which would be extremely painful. So if you get an infection in that fluid, every time you try to breathe in and out, you experience a great deal of pain. That's obviously not trauma, but it's certainly a condition that could cause a large deal of pain upon breathing, inspiration and exhalation, that we may get called for, especially since a lot of people don't understand it. They don't know that it's really a thing, and it could be very, very scary to have pain there. Meanwhile, if something damages the pleuras, you could have a leaking of that fluid, or you could have air get in there, both of which could cause a great deal of pain when you're trying to breathe in and out. So this is anatomy like 8th grade level. We know that the ribs connect to the vertebrae and the sternum. Remember, they don't connect directly to the sternum, they connect to cartilage. So rib to cartilage to sternum. The cartilage is a little bit stretchy, and that's what allows us to breathe in and out. The mediastinum is not of great concern for us. It is the upper portion of the thoracic cavity. Obviously, that's why the great vessels, meaning the superior vena cava and the aorta, especially the ascending, the aortic arch, and the beginning of the descending aorta. Thoracic aortic distension will develop in this area. Diaphragm is a muscle that separates the thoracic cavity and the abdominal cavity and is used in breathing. That is the main purpose of the diaphragm, and it's a rather important muscle for us. Why does it tell us that the thoracic aortic dissection can develop in this area? It is because that's where most of the pressure is, right? The ascending aorta, the part coming directly off the heart before it arches to turn and go back down. So prior to it starting to go back down towards the rest of the body, that's where most of the aortic pressure is. Therefore, it makes sense that that is the part that's most likely to split open. So ventilation, commonly known as breathing. Intercostal muscles and the diaphragm, they work together. They contract. That's the active part. To breathe in, they get smaller. No, they get bigger. No. Yes, they get bigger. Any which way, they're contracting. It's the active part of breathing, is to get air into the body. The body should not have to work at rest. So breathing is passive, right? As long as we are not doing something strenuous, it should not be a big deal to breathe. We shouldn't even think about it. If we have some sort of traumatic injury, especially a blunt force trauma or something encroaching on the lungs, we're probably going to have to work to breathe all the time. So that is something to note. If you get there and they got hit in the chest with a baseball bat, right? I like going back to the bat. Then, and they're working hard to breathe, just sitting there, that's probably the sign of a problem. And problems are what we deal with. Here's a picture of the lungs, inflated and deflated, with the diaphragm doing its thing. So this little bit about where our spinal injury is kind of matters. Below C3, at or below C3, you're probably going to have a patient with difficulty breathing or no breathing at all. The nerves that control breathing are coming off of the C3 vertebrae. So if we have an injury there, breathing is going to be compromised. Below C5, breathing should be fine. So where would we rather see an injury? Below C5, because it's one less thing we are going to have to manage. Minute volume. Minute volume kind of matters a lot to respiratory therapists and doctor people, not so much to us. What matters to us is quality of breathing. So is the patient taking good, deep breaths at an acceptable rate of 12 to 20, really 12 to 20? Or are they tachypnic, breathing really fast, above 20, 24 times per minute with shallow respirations, which is not going to be acceptable to sustain life. So minute volume, knowing how to calculate it, we really don't care. Very small chance of seeing something on tests about this, but then again, you should understand the concept and how to do it. But then again, are we going to be able to get a normal tidal volume amount in the field? No. So know how to do it, but again, it's not something you're going to be able to really calculate because you don't know what their tidal volume actually is. Tidal volume is the amount of air you breathe in and out each time you breathe. So minute volume is that over the course of a minute, and tidal is that each time, like the tide, right? It comes in and it goes out, just like breathing, in and out. Decreased tidal volume, which means shallow breaths, they're going to breathe faster. And that's something we need to manage. We need to try to slow down their rate and increase their volume to have good ventilation. If your patient's not ventilating properly on their own, you spend time, you try to coax them and into doing it right. You coach them, put their hand on your chest, say, here, breathe with me, feel when I breathe in, you try to breathe in then, and do everything you can to calm them and reassure them. If it doesn't work, then we are going to try to breathe for them. Best way to do that, obviously, is with the BVM. And if you breathe them with the BVM and they're still conscious, try to work with them. So when they're inhaling a nice shallow breath, try to force some more air in while they're breathing in. So work with them, and then slowly try to use that BVM to slow them down and to fill their lungs. If you do it right over the course of a minute or two, you and your patient will work together as a team. If you're trying to limit how many breaths they take, initially the patient's just going to feel like you're suffocating them and things are going to go all bad. So this is one of those really hard things that we will do for our patients, and you have to work with them. This is where talking to them, making eye contact the whole time will really help. And you need to explain to them that they're not breathing deep enough, and you're going to help them. But you have to work with them. So we have to start by matching their hyperventilations and try to fill their lungs more each time, and then get them to slow down while you're doing it. Again, it's a very difficult thing to do, but it's very important that you do it and that you work with them. Don't fight against them. Your patient is not the enemy here. So it's funny when you switch screens and you accidentally hit the pause button and you talk for like 2 or 3 minutes on this topic, and then you realize that your recording has been paused. But anyways, I'm new to this just like you, and we will get through it. So 2 types of chest injuries, open and closed. Just like 2 types of femur injuries, open and closed, and 2 types of head injuries, and 2 types of pretty much any traumatic injury. Either the skin is open or the skin is not open. This injury, even though there's a very clear abrasion under the chin to the chest, we would consider this a closed injury. That is not, it's not a laceration. It's not an avulsion. It's just an abrasion. So this is definitely a closed injury, and they are often caused by blunt force trauma. Right? Penetrating trauma by nature is an open injury. We could cause, we shouldn't be doing this. Let's rephrase that. Blunt force injuries could cause significant cardiac and pulmonary contusion. What's a contusion? Right, I think you got it. If the heart is damaged, it's probably not going to refill with blood, or the blood's just not going to be getting pumped properly. This is a big problem. This is going to cause what type of shock? What do we call it? Cardiogenic shock, where shock is caused by a problem with the heart. Lung tissue bruising can result in exponential loss of surface area. So ultimately, if you get smacked in the lungs really, really hard, then you're most likely going to have an issue where the alveoli break down. And remember, you need all those little tiny alveoli, those little balls, for surface area, because a sphere has more surface area than a square. And if you start breaking down those alveoli, you're losing surface area. You lose surface area, you lose gas exchange, and that is a problem. Rib fractures cause complication and damage. So you have a rib that's fractured, it's broken, it's sharp. As the patient moves or you move the patient, those sharp bits of bone are going to start digging into other things, causing more issues. The other and more common issue with fractured ribs is that patients don't want to breathe deep because it hurts. So you now have a patient with a significant traumatic injury, and they're complicating it themselves by not breathing well. And it's just because it hurts. And a lot of times you have to talk them through it. And hey, I know every time you breathe in, it hurts like hell, but you need to breathe in. Otherwise, I'm going to have to do it for you. And it works out a lot better for everybody if the patient breathes for themselves. So our open injuries. I like the list of common reasons. Knife, bullet, piece of metal, broken end of fractured rib. Broken end of fractured rib causing an open chest wound is it's an odd problem. For the most part, that had to be a very significant mechanism of injury to cause a rib to penetrate the skin. This is one where we need to really treat the patient carefully and handle them gently. We don't want that moving around any more than it already has. We certainly can't do much to splint a broken rib. So we need to be careful. Any sort of knife or, sharp metal thing, we don't want to remove from the chest cavity. Chances are that if it went through an important vessel, it's going to apply its own direct pressure. If you remove it, they're going to bleed substantially. So we want to avoid that. Blunt trauma to the chest may cause all kinds of problems. Rib, sternum, and chest wall fractures, bruising of the lungs and heart, damage to the aorta, vital organs to be torn from their attachment in the chest cavity. So that vital organs to be torn from their attachment in the chest cavity. That is something I have not had the misfortune of dealing with. I could only imagine how difficult it would be for things like the lungs and the heart to work properly if they were misplaced, if anything caused them to shift in their location. So not common, but could be a large issue. Rib, sternum, and chest wall fractures are the biggest, more common things. A sternum fracture is not that common, but it could be a very large concern for you. Signs and symptoms tend to be fairly obvious. The pain to the site of injury, bruising to the chest wall, penetrating injury are the most obvious. So you expose the chest and you see lots of bruising to the chest. That's the sign of probably our blunt force issues. Penetrating, you'll see, let's say, the kitchen knife sticking out of their chest. That is the sign of a problem. Localized pain aggravated or increased with breathing. This is often your fractured ribs. And the more they try to breathe, the worse the pain will often get. It is an issue, and it's something you really do need to be aware of. Crepitus. What's crepitus? Crepitus is the sound of bone rubbing on bone. So we could have this with generally your fractured ribs. When you palpate the area, we discussed the other night when we were actually together that you grab the sides of the rib cage and give it a little squeeze. If you do that and you hear like a faint grinding sound, and then you hear patient screaming, owie, owie, that's probably bone rubbing on bone. So we wouldn't want to do that again. I mean, there'd be a big part of you that would say, hey, partner, come here, listen to this. But we should really try to avoid that. And then dyspnea, that is a decrease in breathing, right? So it hurts a lot and they don't want to do it. The problem is we need to breathe. Hemoptysis. The coughing up of blood, that could be a big issue. This might involve suctioning, left lateral recumbent. There's some things we could do to try to mitigate this concern. But ultimately, if they start hacking up blood, it's a problem. So asymmetric expansion of the chest, also a big issue. Generally, collapsed lung is causing that. So, or a major rib fracture is causing that. So we definitely need to expose the chest and look at it while they breathe. Is it good and equal throughout the chest whenever it expands with ventilation? Rapid weak pulse and low blood pressure would be the sign of a problem with the heart. Cyanosis around the lips or fingernails would be the sign of a problem with perfusion or direct lung injury. So we need to be aware of all of these things because they are fairly large concerns. Remember, cyanosis is that blue color. So we discussed this a few slides ago, and we need to be aware that this patient might only be moving air through the dead space. Basically the area between the mouth and the lungs, and not actually getting new air in and out of the alveoli. Auscultation is important, especially at the bases of the lungs. So the lower parts of the chest where we auscultate, we want to make sure that we do this and listen. If there's diminished breath sounds and signs of cyanosis and other complications due to insufficient breathing, we need to make sure that we do something about it. And it might be as simple as say, hey, deal with the pain, jackass, and breathe. Scene safety, obviously. Is everybody safe? Is the scene safe? Is the person who shoved the knife in your patient's chest still around and still acting crazy? If it's a crime scene and you do disturb evidence, make sure that you make a note of it, and at some point you need to notify law enforcement of what you touched and where you put it and where you found it. Today's day and age, law enforcement is requested for us. Very rare now that we get somewhere and have to call law enforcement, but it can happen. It might be something where you have to do so subtly so your patient and or bystanders do not hear you say, hey, I want cops here. You might have people that are fairly calm and cooperative change their tune quickly when they hear you are asking the police car drivers to join you. So gloves and eye protection, obviously gloves on every call. Eye protection is becoming more and more of a staple, especially for traumatic injuries where stuff might get squishy, gooey, and splashy. And if there's any chance of you getting your patient's fluid splashed in your eyes, eye protection is a great thing. Ambulance corps are getting a lot better at providing proper eye protection, your wraparound OSHA approved safety glasses. We don't necessarily need a full goggles, but we might also concern our surgical mask with the built-in face shield, eye shield. Those, again, with this whole corona nonsense, are becoming more and more common, and they should be on your ambulance and readily available. So, mechanism of injury. Our motor vehicle crashes are big ones. Assaults are the other one. MVCs, we need to be aware of things like speed, of the collision, what they actually hit. Did something hit them? Number of patients, obviously important. Luckily for us, most situations will only have one major patient. Every once in a while, you'll get a severe car crash that will involve multiple patients. And then you have to triage and figure out who needs your help the most. And if there's somebody that has something major going on that you could easily fix, like severe bleeding, can you throw a tourniquet on them and then go and deal with the patient that has severe chest trauma? Seatbelts are our friends. Airbags are our friends. Together, they're really our friends. When you have one, not the other, injuries do increase. If somebody is not restrained with a seatbelt, but they did get airbag deployment, you could have a whole bunch of worse injuries from the airbag because they weren't initially restrained by the seatbelt. Remember, those things are supposed to work together. When you have an airbag working all alone, then there's a good chance that they're going to hit that airbag with a little bit too much force. And then chest trauma, abdominal trauma is very common. And consider spinal immobilization. Do we remember our reasons why or why not to collar? Collaring is something that we do still do according to mechanism alone. So even though they're not complaining of any pain or anything to the neck, we could still consider putting it on. In general, if you apply that collar properly, it could only help. It's not going to hurt them. General impression. Is it stable or poor? Address life-threatening hemorrhage immediately. Yep, we are sensing a pattern in this class. They really want you to deal with life-threatening bleeding. Level of consciousness should be noted early on, along with your baseline vitals that we're going to try to get within the first 2 minutes of patient contact. If we cannot get in the first 2 minutes at some point in documentation, we should take a sentence or two and, explain why we were unable to. And there's myriad good reasons why I could not get my baseline vitals in the first 2 minutes of patient contact. But we should be aware that we did not and document why. Not a big deal if you document it. It could become a big deal if you totally omit any mention of it. Rapid physical exam, especially for the unconscious. You want to try to, poke and prod head to toe real quick and look for signs of injury. Make sure that we don't get the tunnel vision and that we address all injuries, starting with the most life-threatening. The rapid scan involves our trauma naked, right? And yes, even if they're over 30, as much as we don't want to, we should cut those clothes off. Chest rise and fall on only one side, we need to definitely note that and be prepared to do something about it. Sometimes positive pressure ventilations, the BVM, could help get that lung, the one that collapsed, to expand again. If we have a pneumothorax and there is penetrating trauma to the chest wall, there's a good chance that if we occlude, if we put an occlusive dressing on that, we'll be able to normalize the thoracic cavity pressure and get that lung again to expand with some positive pressure ventilation, or just with the patient breathing on their own once there's no longer a gaping hole in their chest. Accessory muscle use. This we tend to see on children with difficulty breathing, but if we see it in the adult patient, it's definitely an issue that needs to be addressed. Extended or engorged jugular veins. We see this on our charting systems as JVD, or jugular venous distension. If you see this, especially if they're pulsating, that is a big sign of some sort of pressure problem or a circulatory problem in the chest. So if you have too much thoracic pressure and the blood could get up to the brain but not back down, that is why those veins are going to get distended. They are ultimately engorged with blood that can't get back to the heart. So that's a problem. Assess the ABCs, obviously, and look at their overall appearance. Do they have that gray, clammy, shocky look to them? We'll be aware of that and try to do something about it. Remember, blankets are your friends. Ensure the patient has a patent airway. If it's not clear, you might need to suction. Cervical spine, early and often in these traumatic injury cases. Again, note distended jugular veins. Check respirations, make sure that they're present and adequate. Remember, we don't just care about quantity, we care about quality when it comes to pulse assessment and breathing assessment. See, even I call it respiration assessment. Inspect for your DCAP BTLS. What's that? Deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and severity. I think that's it. You better check me on that. Make sure I'm right. If not, please let me know. Again, equal expansion of the chest wall. This is important. Blunt force trauma, penetrating trauma to the chest. We really need to make sure that both lungs are working and working equally. Paradoxal motion. What is that? Paradoxal motion is the one section of rib moving out when the rest is moving in. So this is our flail segment. Flail segment is 2 or more ribs broken in 2 or more places. So you basically have a little rib island floating in the middle of the rib cage. So when you breathe in and your chest wall expands, that little section gets sucked in. Because remember, there's negative pressure when you breathe in. So that vacuum in your chest wall is going to suck in that section of rib. And then when you breathe out and you have the positive pressure situation, that section is going to get pushed out. Apply occlusive dressings to all penetrating injuries. So assuming you have a penetrating injury, somebody stabbed them and pulled the knife out themselves, or they were shot with a bullet, shot with a gun and had a bullet go through their chest, we can occlude that hole so that air cannot get into it. If air already got into it and they're having signs of pneumothorax, difficulty breathing, unequal chest rise and fall, maybe tracheal deviation, where the trachea is actually moving toward the side of the injury, or the side away from the injury rather, you are going to want to do a semi-occlusive dressing, right? Keep that little corner open so air could get out, and then when they breathe in, that negative pressure will suck the dressing into the hole to occlude it, and then when they breathe out again, it'll open up if there's any pressure that needs to get released. So that is your semi-occlusive and occlusive dressing. Tape down all four sides for the occlusive dressing, leave a corner open for the semi-occlusive. Obviously, support ventilations. Reassess the effectiveness of ventilatory support. So when you're bagging them, make sure that you're batting them effectively. Not too fast, not too slow, with good depth, and that their body is getting good oxygenation. If you have signs of cyanosis and whatnot, you might have to reevaluate your efforts. Be alert for decreasing oxygen saturation. Be aware that it might be due to poor peripheral perfusion. So we have a shocky patient and their vessels are starting to shunt blood away from their extremities. You might have a patient whose face and core appear to have good oxygenation, and your pulse oximeter is reading 89. So let's make sure that it's because you are not ventilating them properly, as opposed to the body taking its own efforts to support the core. So we have to be aware of that. At that point, is their core and face good, pink, looking well, and their arms are kind of cool, and their hands are cold and maybe a little cyanotic? So we need to, look at the big picture and factor in, is it because I'm not properly ventilating this patient that their oxygenation saturation is showing at 89, or is it because their system is shunting? So be aware of that and try not to hyperventilate the patient because their hands are a little bit blue. Look at the big picture and remember that the core is what matters. Their chest and abdominal cavities, their head, their face, that stuff. That is what the body cares about the most. That's what you should care about the most. And be alert for impending tension pneumothorax. Remember, at any point, things could be looking all right, and then they could develop that pressure situation in their chest, which is called a tension pneumothorax if it's caused by air getting in where it shouldn't be. Circulation, pulse rate and quality, skin color and temperature. Life-threatening bleeding of immediately, direct pressure and bulky dressings are the patient's friend. Transport. Problems with your ABCs. Transport quickly. Pay attention to subtle clues. Not my strong point. I am not a subtle man. Appearance of the skin, level of consciousness, sense of impending doom in the patient. Your patient says, I think I'm going to die. That is a reason to be concerned. If your patient thinks they are going to die in a severe traumatic situation, you should assume that that's their body telling them that they're probably going to die, and you need to work aggressively to keep it from happening. So here's a really cool chart, the Deadly Dozen. That's from the movie, I believe. What's that army movie? The Dirty Dozen. Yeah, they're definitely playing on that movie title, which was a great flick, by the way, for you youngins in there that haven't seen it. Yeah, read these at your own time. My biggest concern, esophageal injury, big issue, flail chest, huge. Your pneumothorax, tension pneumo, open pneumo, massive hemothorax that's bleeding in the thoracic cavity. These are all big problems. Thoracic aortic dissension from a traumatic aneurysm of the portion of the aorta that lies within the chest, that could mean certain death. So we need to be aware and not dally on scene with these patients. Of course, investigate the chief complaint. Look at the car. Look at the machine that ran over them. Or look at the impeller that they got their arm stuck in. Oh, I'm sorry, this is chest trauma class. Look at the bat that smacked him. Identify signs, symptoms, and pertinent negatives. Here we are with pertinent negatives again. Patient did not lose consciousness. Patient does not have external bleeding. These are pertinent negatives that should be notated or noted. Basic evaluation should be completed with a sample history. We might have to do our sample history en route to the hospital. We're not going to hang out and waste time to do a sample. Isolated injury, focus on that injury. Focus on the patient's complaint. Focus on the region affected by the isolated acute injury. Look at the front and back, the anterior and posterior aspects of the chest wall. And look for changes in respirations. Are respirations getting better? Are they getting worse? Is it because the patient's freaking out, or there's actually a medical situation going on due to this traumatic injury? Physical exam, significant trauma likely affecting multiple systems. Start with a rapid physical exam. And that's, your top to bottom, head to toe, quick look, poke and prod at everything. Decap BTLS to determine the nature and extent of the injury. Vitals, again, as soon as possible, as often as possible. Pulse, respirations, blood pressure, skin condition, pupils. We need to check pupils for reactivity. Do they get smaller when I put the light in them? Do they quickly get bigger when I take the light away? Are they equal and round? Our pulse is rate and rhythm. Our respirations are rate and quality. Our blood pressure, we're going to look for numbers getting further away from each other, closer together. Is the blood pressure going up? Is it going down? Is it staying about the same? Our skin, are we cool and clammy? Are we hot and dry? And does it seem normal? All this stuff matters. Pulse and respiratory rates may decrease in later stages of the chest injury. This, of course, is matching our shock, right? Repeat the primary assessment, reassess chief complaint, reevaluate all the important things to living. Perfusion, again, we're checking to see if they're going into a deeper state of shock, if they're coming out of compensated shock and going into full shock, that kind of stuff. We need to keep assessing. Reassess our vitals and trends before and after our interventions, especially after. So we intervene in a problem. We need to make sure that it had a good effect, not a bad one. Maintain the open airway, consider spinal stabilization, significant bleeding, occlusive dressings over penetrating trauma to the chest wall. What could we do if the knife's still sticking out of it? That would be a time to wrap some bandages around it, get out the 2-inch tape and tape everything down as best we can. We might need our friend the towel to get rid of some of the blood. If a lot of blood leaked out of the wound, we all know tape does not stick to blood. We also should have Vaseline gauze in our ambulance. It might be a situation where we have to stick Vaseline gauze on it because that will become an occlusive dressing. Air does not get through Vaseline impregnated gauze pads. So you might be able to sort of push them against, well, not push hard, but, get them right in there against the knife or whatever's protruding from the chest wall and get it to stay close, and then wrap some gauze around it and maybe tape down whatever's over the. But here again, we might have to get creative. Don't be afraid to take a moment with a towel and get rid of the excess blood so that you could get tape to stick. Significant hypoperfusion. Treat aggressively for shock and transport quickly to an appropriate facility. Do not delay for non-life-saving treatments. So the only time we're going to delay transport is for an immediate life threat. Communicate all relevant information to the staff at the receiving hospital. This is going to start with your med patch. You're going to make sure that they know when you're patching in that your patient has significant injuries. Answer all their questions, give them as much information as you deem necessary on a patch, and then you're going to communicate every little detail to them once you arrive and do your handoff report. Pneumothorax, commonly called a collapsed lung. Accumulation of air in the pleural space. Blood passing through the collapsed portion of the lung is not oxygenated. You may hear diminished or absent or abnormal breath sounds. So a pneumothorax is important. Remember, pneumo infers air. So sort of like, I don't know, all the other things in the world. Pneumatic tires, which are air-filled tires. Pneumatic pumps, air pumps, that kind of thing. Hydraulic means fluid. Hemo means blood. So here we go. Here's a nice picture of a pneumothorax. Parietal pleural space, air in the way, and then the lungs in there collapsed. So it should be nice and big. It should be right up against the parietal pleura with just that little bit of fluid between the visceral and the parietal pleuras. Here we have air in there, and that lung's not going to get big if you have air outside of the lung. Open pneumothorax, or a sucking chest wound. There is a video of this. I will make sure it's attached to this chapter in the Navigate 2. But it's a patient in the ED being treated for it, and you could hear the wound making noise. Wounds must be rapidly sealed with an occlusive dressing. So the sucking chest wound, we want to get something cover it, so when it tries to suck air in, it cannot. Monitor the patient for the tension pneumothorax. If it appears to be becoming pressurized, hence the tension, we need to remove flap and let the air out on exhalation. Then we need to make sure it gets covered again when they breathe in. Oh, I can't go back. So it mentioned the flutter valve. That is your semi-occlusive dressing where you keep one corner uncovered so that when they breathe out, that air could escape. But when they breathe in, that little flap will get sucked down and no more air could get into it. So here's our picture of the hole in the chest wall letting air in and out. Simple pneumothorax does not result in major changes in the patient's cardiac physiology. So it's really not going to screw with the heart too much. Generally common to the blunt trauma that fractures ribs. It can get worse and deteriorate into tension pneumo, which is a big issue. Ongoing air accumulation in the pleural space. So ultimately, if we do not seal off that hole, it's going to develop into a tension pneumo. Every time they try to breathe in and that chest wall expands, air is going to get sucked in, and that's a problem. It will cause complete collapse of the ineffective lung eventually. Mediastinum is pushed into the opposite pleural cavity. That's a problem. And again, commonly caused by blunt injury, where the fractured rib lacerates the lung or bronchus. So you could picture that in your head, right, as that being a problem? I don't normally go into deep detail on the pictures, but this one's a really good one showing all the different complications with increased thoracic pressure from pneumothorax. So you see your little wound site there. It collapsed the lung. It's letting air get in, and it's creating increased thoracic pressure where it shouldn't be. And then all these other things are getting complicated. So you have bulging muscles, intercostal muscles are starting to bulge out. Your vena cava is getting compressed. Your aorta is getting compressed. The heart's getting compressed, which means that you're going to have decreased cardiac function. And that, my friends, is a problem. So hemothorax means that instead of air, blood is collecting there. And blood around the rib cage or from a lung or great vessel in the pleural space is definitely a problem. So there we go. This patient's obviously standing up in the bottom picture. because you would not have the blood pooling at the bottom if they're lying flat on their back or supine. So we can imagine that this patient is somehow having this issue and still either sitting up or standing up. And that would really be a good thing, that they can still sit up or stand up. Given the position of the heart, it might not be a good thing for the heart and its function, but this is a problem and needs to get addressed. Shock without any obvious external bleeding or apparent reason. Decreased breath sounds on the affected side. So at least at the beginning of a hemothorax, the unaffected side, the lung's still working fine. We need to get them to the hospital. A diesel bolus is the only thing that will help this patient. And they need to go to a trauma center because they need somebody to go in and release that pressure. Most of your Band-Aid stations, like Sharon, New Milford, Charlotte, can and will do a chest tube to get this bleeding out of there. What they tend not to be able to do is solve the cause of the bleeding. So if you have a severely shocky patient, signs of major pneumothorax, you might need to just get them to the closest facility so that they could get that blood draining out, maybe get some fresh blood draining in, like a transfusion, and then they could get transferred out to definitive surgical care. So this is one where you have to look at your patient, look at all the signs and symptoms, look at the vitals, contact medical control, and together come up with a plan for what's best for your patient. If you're heading down the New Milford way, there's a good chance that New Milford's not going to give you an option. They're going to say, we're not going to take this patient, period, end of story. I don't care if they live or die. Unfortunately, that is the way their protocols work now, and it's kind of sad. Sharon and Charlotte are going to be a lot more forgiving. They're going to be a lot more willing to recognize a severe medical emergency and say, hey, yeah, take them here, get them stabilized, and then we could deal with it from there. Hemopneumo. This is like the holy grail of thoracic injuries, where we have air and blood in the pleural space. This is definitely a problem. And then our cardiac tamponade. It's a neat word. It's kind of cool. This is where the pericardium, the protective membrane around the heart, is filling with blood. Eventually, the blood will not be able to pump. It's just all the blood's in the wrong spot. The heart gets pressurized, and it cannot expand and contract like it should. Specifically, it cannot expand because there's blood in the place where it should be expanding to. This is one that doctors could see on an ultrasound quite clearly. And again, they could take steps to mitigate even at a non-trauma rated hospital. But ultimately, this is a patient that needs definitive surgical care. Not something we could really tell in the field other than they're showing signs of shock, and their mechanism of injury would indicate that there's a chance that the area of the heart was damaged. This might not present with any kind of bruising to the outside of the chest. You might not have any real way of knowing. It might be a situation where you suspect it, where their vital signs, their level of shock, and what actually happened to them to cause the ambulance to show up have to be factored in, and you have to say, hey, self, this might be the situation going on here. So there's a nice picture of it. X triad is increased jugular venous pressure, which would be our jugular venous distension, is how we know that. Hypotension, and we know that by taking their blood pressure and finding it to be low, with a diminished heart sound. And we're probably not necessarily auscultating for heart sound, but if we're auscultating for breath sounds, when we get on the left side, we tend to hear the heart beating. So if we don't hear that, then we know that they're in Beck's triad. This is a problem. And of course, altered mental status. When blood's not flowing, the brain suffers, right? So these patients should present with an altered mental status. Support ventilations, treat for shock, and transport rapidly. Rib fractures, common, particularly in older people and people that are younger and like to fight. Fracture of one of the upper 4 ribs is a significant sign of a substantial MOI, mechanism of injury. Fractured rib may cause a pneumothorax, hemothorax, or hemopneumothorax. Remember, where's that broken rib section poking? If it's digging through membranes and such, you might have a more significant injury. A lot of times the intercostal muscles will keep the ribs in place, and it will be fractured. It will hurt to breathe in and out, but they won't have any other substantial secondary injuries due to the broken ribs. Localized tenderness and pain upon breathing, rapid, shallow respirations, holding the affected portion of the rib cage. Pre-hospital treatment includes oxygen. And quite frankly, if they cannot push through the pain and breathe for themselves, it might include bagging them. Flail chest. Here we are. Compound rib fractures that detach a segment of the chest wall. So we generally have 3, I think I said 2 before, 2 ribs in 2 sections, 3 ribs in 2 sections. So each rib is broken in 2 places. Flail segment is generally 3 ribs that are broken together. And it will have that paradoxal movement. It will move opposite the rest of the chest wall. Airway, respiratory support, supplemental oxygen, ongoing assessments. It is a case where if you feel you have the time and the means and the manpower, you can wrap the chest with like an ace bandage or something and try to keep that flail segment from bulging out when they breathe in. It's not going to do anything for it getting sucked in or bulging out when they breathe out. When they take a deep breath in, that section's still going to get pulled in by the negative pressure, but it will stop it from pressing out. And you might relieve some of their pain. It won't really do much more than relieve some pain. Positive pressure ventilation with the BVM, restrict the chest wall movement, is no longer recommended. Oh my gosh. So everything I just told you, forget it. Further proving how old school a provider I am. So I was giving you bad information according to the latest science. Restricting the chest wall movement is no longer recommended. Flail chest may indicate serious internal damage or spinal injury. You think if something was of great enough force to fracture 3 ribs in 2 or more spots, it might be a significant situation. But that second dot, restricting chest wall movement is no longer recommended. You know, I was so proud of myself for telling you all about how to restrict that movement. Sorry. Pulmonary contusion. Be suspected in a patient with a flail chest. We should probably suspect it for any fractured ribs. There's a good chance that you have caused a contusion to the lungs. Alveoli become filled with blood, leading to hypoxia. Supplemental oxygen, positive pressure ventilation if called for, and rapid transport. Fracture to the sternum create an increased index of suspicion for organ injury. Remember, the sternum is a fairly strong bone. So if you're breaking that, it was a tremendous amount of force. Clavicle fracture, damage to the neurovascular bundle. Suspect upper rib fractures and medial clavicle fractures. So if you break the clavicle, there's a good chance that other stuff is broken too, is what they're getting at. Be alert for the pneumothorax to develop. It is quite common in clavicle fractures. Damn, look at that neck. Looks thick, right? Not suspected. Traumatic asphyxia. Distended neck vein, cyanosis in the face and neck, and hemorrhage in the sclera of the eye. What is the sclera of the eye? It's the white part. If you see red where it should be right, that is the sign of hemorrhage in the sclera of the eye, generally caused by a severe increase in cranial pressure. And specifically more than cranial, but the vessels of the skull are having an increase in pressure, and those fine capillaries in the sclera burst open because they can't handle the increase of pressure. Traumatic asphyxia, severe compression of the chest, which will cause the lungs not to get big and small properly, cause the heart not to pump properly. Underlying injury of the heart and pulmonary contusion are most likely. Ventilatory support, supplemental oxygen, frequent vital assessments, and immediate transport. Blunt myocardial injury, bruising of the heart muscle. This, again, motor vehicle collision, airbag deployment, no seatbelt worn. Myocardial bruising is quite possible. Irregular pulse rate, chest pain, discomfort, and then signs of shock as time goes on. Suspected in all cases of severe blunt injury to the chest. Pre-hospital treatment, carefully monitoring the pulse, noting changes of blood pressure, supplemental oxygen, and rapid transport. Commotio cordis, direct blow to the chest during a critical portion of the heartbeat. Oh my gosh. So ultimately, the heart gets the signal. It does that beat. It's in, that split second of the heartbeat, and it has a traumatic injury to the chest, which can cause the heart to either just get all sorts of confused or shut down completely. This is something where rapid defibrillation can fix it, but it has to be rapid. Laceration of the great vessels, rapidly fatal hemorrhage. I mean, that makes sense, right? You blow out your aorta, you're probably not going to live more than 45 seconds. You're going to try to resuscitate with CPR. Chances are it's not going to work because all you're going to do is pump what little blood they have left in their circulatory system out through the gaping hole. Ventilatory support, obviously. Immediate transport, alert. Be alert for shock. They're probably already in shock if this is going on. And changes in baseline vital signs. So ultimately, you could have a small laceration in a great vessel. They are suffering internal bleeding, but it's slow, and rapid transport could be the solution. But their vital signs are going to worsen throughout time. So as you care for these patients, you need to carefully monitor their vital signs and look for downward trending. Hot damn, we did it. That was an hour. I'm going to include the review questions here. Maybe given that we're not doing this in depth together, it will be something you want to go through. The chest impacts the steering wheel during a motor vehicle crash with rapid deceleration. The resulting injury that kills almost 1/3 of patients, usually within seconds, is, I'm going to say B. Hey, I was right. When the chest impacts the steering wheel following rapid forward deceleration, aortic injuries or shearing or rupture are the cause of death in nearly 2/3 of patients. The aorta is the largest artery in the body. When it is sheared from its supporting structures or ruptures outright, exsanguination, bleeding to death, occurs, usually within a matter of seconds. Yes, if you rip open the ascending aorta, you're going to bleed out in, again, 45 seconds, you're done. What's next? Maybe we're not done. This is only 65 of 102. So I'll give you a chance here to read these. go faster because ultimately you could pause and review them, and I'm well aware that most of you aren't going to bother with this. You should. It could only help. It will not hinder. But again, if you want to read anything in more depth, just hit the pause button. I'm still here, I swear. Now, while I'm doing this, let's say you have a question on any portion of this. I should have done it at the beginning, but I do not know how to go back to the beginning and add more stuff to the recording. And I'm sure as heck not going to redo this whole thing. So you could call me. You could text me. I think there's a way to do like questions and comments in the YouTube section. You could send me an email with all your questions. But any which way, even though I'm not physically present, I am absolutely here for you to make sure that you understand all this stuff. And I will do whatever I can to support you. So I hope this works out and you like it. And if not, too bad, because it's making the powers happy that we're doing it this way. And it's allowing us to continue with some modicum of success.